Imagine you or a loved one had a severe head injury and you were unlucky enough to have your brain squished by a hematoma inside your skull, pushing on the brain, an extradural, also known as epidural hematoma. What would you want for yourself or your family? You would want a skilled neurosurgeon with the right equipment to decompress your skull. And if you didn't have that, you'd want an emergency physician with the appropriate neurosurgical equipment, even if it's something simple like this Hudson brace, to decompress it if you can't get to a neurosurgeon on time. But what drills do we have in the emergency department? We're all very familiar with the Easy IO intraosseous needle. What about using that? Would that be appropriate as a way of performing an emergency evacuation of a hematoma? I asked Professor Mark Wilson, one of the smartest people in the universe, an extremely highly qualified resuscitation doctor, surgeon, neurosurgeon, pre-hospital emergency medicine physician. He's got qualifications in anesthesia, and he even has a medal given to him by the king. Now, Professor Mark Wilson has such an enormous brain, but he squeezes it into a normal-sized head, which makes me worried that his own intracranial pressure might be very high. I put to him a theoretical case of someone crashing on a mountain bike and getting an extradural hematoma and asked him what he thought would be appropriate. Before we crack on with that, let's just clarify some terminology. With operations, if you have an ectomy, it's when you cut something out. Think appendicectomy or appendectomy. So a craniectomy, they remove parts of the cranium, parts of the skull, and usually leave a gap there. An otomy is when you cut something or make an incision. Think about thoracotomy to get into the chest, or a pericardotomy to cut through the pericardium. And a craniotomy also usually involves removing parts of the skull, but not as big as craniectomy and not usually leaving a big hole there. An ostomy is when an opening is made in an organ. Think about tracheostomy or colostomy. And a craniostomy is what we're talking about here. It's when we're making a hole, also known as a burr hole, in the appropriate place to evacuate an acute expanding intracranial hematoma. So a burr hole is a kind of craniostomy, and what we're talking about here is an emergency burr hole or resuscitative craniostomy. And what we're asking, is it appropriate to use an EZIO to do a resuscitative needle craniostomy, or is that just not likely to work? Now, there are some case reports. There have been publications since 2017, but in all that time, of 6 published case report patients, there have only been 4 survivors to neurological discharge, which makes me wonder, if it's been tried many times, we've only managed to publish 4 survivors with neurological recovery. How many times has it been tried unsuccessfully and therefore not published? Is there a publication bias here, and is it unlikely to work? So the case I put to Mark was of a middle-aged mountain biker falling off and banging his head. Following a brief loss of consciousness, he feels fine, but gets a worsening headache and goes to the emergency department and appropriately gets a CT scan. However, he deteriorates in the scan and becomes comatose, and the radiographer brings him back to the ED. The scan shows a huge lens-shaped intracranial hematoma, therefore an extradural or epidural hematoma, pushing on the brain, causing significant midline shift, effacement of the ventricles there, and this mass effect is causing the patient to become comatose. He clearly needs a neurosurgeon. However, he's now becoming hypertensive, bradycardic, and is dilating one pupil and then the second pupil. We need to get him to a neurosurgeon, but in this hypothetical scenario I put to Mark Wilson, we were 90 minutes from a trauma center with a neurosurgeon. It was bad weather, it was nighttime, and this patient is essentially herniating in front of us. What should we do? Let's see what Mark said.
Well, maybe we can roll back a little bit for this, because there's a few things to explore in all that, isn't there? Before you sort of make it, and you've given us sort of like that knife edge kind of scenario there as to 90 minutes. Do you transfer? But let's just roll back a little bit. So what you described there is a sort of classic talk and die extradural kind of involvement. So the first thing, extradural. This is a arterial bleed from a ruptured middle meningeal artery, usually, or branch of middle meningeal artery, stripping off the dura from the inside of the skull. So it's forming a sort of lens-like crescentic bleed, which, just to emphasize, to people who are familiar with lots of the breadth of brain injuries, this is not actually a brain injury. It's a bleed outside the brain that if you leave it there, and puts pressure on the brain, it will cause a brain injury, but the bleed itself is not a brain injury. So these people, if you evacuate it immediately, do really well. But if they accumulate, pressure, ischemia, then they end up with a brain injury following that. And the treatment for these is usually evacuation. Obviously, small ones we can manage conservatively, but as they're getting larger, they're going to need evacuation. The difficulty with extradurals is that they're often well, clotted blood, so that you may not be able to treat it with a burr hole, but you almost certainly in a neurosurgical setting you'll end up doing a craniostomy to evacuate that properly and get control of the bleeding. So the system, what you described there is, it's a relatively rare event, extradural, and also just to emphasize here, extradurals are usually caused by people being hit by something, or their head hitting hitting something like a concrete block if they fall off their bike. But they're not the deceleration injuries that we see with subdurals, where there's shearing and there's diffuse axonal injury and there's bleeding from venous structures as well. But the question is how quickly they can get to definitive neurosurgical care. Obviously, in the vast majority of circumstances, you want to transfer this patient to a neurosurgical center where you've got the right equipment, right nursing staff, theatre staff, everyone's familiar with everything, and they get the proper procedure done immediately on arrival, and that's the best thing to do. I think what you're alluding to here is in the situation where you're in a very remote environment. So rather than do that 90-minute thing, which is a bit sort of like, do you, don't you? Let's put them in a place where they are in a ski resort, a ski local hospital, which is, completely locked down. There's no ability to get out. It's snowing. You're going to be there all night. You can't escape from it. So that's a more definitive type scenario where you're going to, well, actually, you have no choice but to try and do something in those circumstances. And in those sort of circumstances, my advice would be to be prepared. So, isn't it proper preparedness prevents piss poor performance? Be prepared. So, if you're working in an environment where this is likely to occur, if you're in a rural hospital in the middle of a long, long way from any kind of definitive treatment, then you should have a plan for this. And that plan will involve something like an SOP or some kind of guidance about who does it, when, what your time frame for doing it is, and more importantly, what equipment you're going to use. Because if you haven't got the right equipment, then you're increasing the risks associated with this. And I know people go on about using IOs. We can talk about all this kind of thing in a minute. But that's a bit like me saying, I did really amazing intubation the other week. I didn't have any armor. I just used a McDonald's straw and a tongue depressor. You'll be going, what is this loon? And it's a bit like that when people start talking about using IOs to me. I go, well, hang on, just use the right equipment. And the right equipment is pretty simple. I mean, I've got one here. I'll show you. This is a perforated drill bit. So I don't know if you can see that there. But it's basically a drill that you can buy. You can stick it on anything like this. So you can put it in your own hand. I need to turn up a black brown blur, but you can put it in literally an electric drill or anything that will hold the drill bit in it. And what happens is when that pops through the skull, I can show you on a bit of a picture here as well. Let me just share my screen here. This is what it looks like. If you can see this.
Yep.
Can you see it? So if we see it looking at it, so if you look at this drill bit here, when it pops through the skull, it disengages. So it cuts out. So this is a really safe way of drilling into someone's skull if you needed to do this, especially if you're not familiar with doing it. It's not like a standard Hudson brace, which can easily plunge. This will cut out. So if you're working in an ED that's in a remote environment, then, as I say, before you do anything, preparation is a good thing. So having a drill bit like this would probably be a bit like having a fire extinguisher. It's ready there if anyone was ever to need it. And then the next bit about what you're saying there is about getting advice and doing it. So this is in today's world when you can do stuff, through telemedicine, be guided through how to do stuff. Or if you've been familiar, maybe you've done a neurosurgery SHO reg job in your training and you're a general surgeon, and think, well, actually, I can do a burr hole because I did plenty as a junior, then that's fine. But with today's telemedicine, you should be able to be guided through that if you had to in a remote environment by a competent neurosurgical person. And the question there is about how do you go about doing it. Now, we wrote this paper, which I just showed you a screenshot of there, which I can give you a link to, called How to Do Burr Holes. It's pretty easy. These are not particularly, doing a burr hole is not a difficult procedure. It's like doing a thoracostomy, really. It's a it's a simple thing to do, but you've got to know it's more about the preparation. So positioning the patient, making sure you've got your landmarks. You know where you're going to do this. Now the if I just share my screen here again, you said it was a temporal burr hole there. Now, one of the things I would suggest, I don't know if you can see this here. There's a CT scan here, and you can see this person's got a frontal extradural, and they've got some dark blood in there. That
Yeah.
dark blood is not chronic blood, that's hyperacute blood. So it's still bleeding into that. So that means that person's not going to last the 3 hour, 4 hours transferred to a hospital if you're really remote. So this is the kind of situation where you may well think, well, actually, I've got to do something where I am. And this is not something in the UK. This is incredibly rare. I completely see in Australia or other places where you've got long distances to travel. This might be more realistic. Um, and the world of what we used to talk about exploratory burr holes, that should just not be a thing anymore. Pretty much everywhere's got a CT scanner.
Yeah.
So you should be doing targeted burr holes. And when you look at it, the majority of extradurals occur in the temporal region, then frontal or parietal is the other place they occur in. And you want to be targeting the area that extradural is in. Now, when we're doing them preparing for a craniostomy, we will do them in a position that will enable you to join the dots effectively and do a craniostomy. So they form that question mark type incision. So the first thing is getting the correct side. That's really quite important. So that's obviously your left and your right, the side that the pupil blew first on usually. They may well have more injury on that side. You may well be able to feel a fracture. All those things indicate which side, but more importantly, you're going to use your CT scan to guide you in that. And then you're obviously going to have to make a cut in the skin. So that means that ideally you want to be doing this in an environment where there's diathermy and self-retainer type equipment available. And then once you've made the hole in the skin and remove the periosteum, it is fairly simple just to do a burr hole with a perforated drill bit like this. You'll get left with a little bit of bone, a small remnant of bone at the end, which you can flick out, and then the extradural blood should come out. So it's a relatively straightforward procedure, much safer if you use the right equipment.
What are the alternatives if you don't have the right equipment? Let's say if you were forced to use the McDonald's straw analogy.
Yeah, so I know people talk about using IO needles and things like that. So we've done that. I've done that occasionally. When, let me give you an example. Someone's had a malignancy, a sort of hematological malignancy. Their platelet numbers are 0 or virtually 0, and you're going to be a long while waiting for platelets. Then actually, this is not necessarily a bad thing in those situations because because the blood is very, very liquid. But in the majority of cases for extradural, or certainly for a subdural, the blood is clotted and it doesn't come up easily through an IO needle at all. And although there are many case reports, and I've been to presentations where patients have survived and it's all looked really good, I would, and if you have no choice but to use anything else, I guess, there's case examples and people do survive it. But I just can't emphasize enough using the right equipment if you can. It's because it probably would scare you talking about it as if I was going to say, well, I've got a McDonald's straw or whatever. Don't do that.
Yeah. And I went on a course, it's actually a really good course, the procedures course at the Alfred, and they cover a lot of the halo procedures. And when they were teaching resuscitative craniotomy to burr holes, they used the drill that comes in a ventriculostomy kit, which was a little
tiny one
thingy there.
Yeah, so I haven't got one of those on me. So the little hand drills, when you do that, you get a small drill bit, which will give you a small hole, like literally probably about 4 millimeters maximum in diameter. Which again is probably not enough to drain clotted blood, but it might be enough to relieve a little bit of pressure. And again, the most important thing about that is when you do that, there'll be a little a collar on that drill bit, which you can set to the depth you want to drill.
Yeah.
And you get used to doing it as a neurosurgeon. You can kind of look at someone and go, well, that's their skin thickness plus their bone thickness, and you set it to the right depth. But it's probably about, I don't know, an inch, maybe just under an inch in total. You want to have that depth at, so that you don't plunge into brain. Now, if they've got an extradural there, that should be fine because actually you're going to go into blood. But nonetheless, you just want to just go through the inner table of the skull and not really go beyond that. And that's the other thing. You can feel your way through skull when you're doing this. When you start to drill, you'll feel yourself go through the outer table, then it'll get a bit easier, and then you'll feel it'll get resistance again, and that's when you know you're about to go through the inner table. The reason why I used to talk about burr holes and things like that was because I think it's a really good way of engaging people in brain injury in total. So, like in terms of, here's a practical skill that you may need in a very rare circumstances. And there should be a way for people who are working in remote areas, as you say, you call it a halo procedure, to practice these procedures. It's a bit like a thoracotomy if you're doing pre-hospital care. It's relatively, unless you work in London or somewhere where there's got stabbings, it's a relatively rare event, but actually you need to be competent in doing it. And it's similar like this. If you're working in, I'm picking places here like Wyler or somewhere that's remote, or that you're going to take 2 hours to get to the nearest neurosurgical center, then actually you probably should have a general surgical reg team who are competent in doing this. And that just means, once every year or so, just going through the procedure and being signed off on it again.
And, before you were a neurosurgeon and HEMS doctor and the other things that you do, you were a rural GP in Australia, weren't you?
In Wyler, which is why I picked Wyler, because I know it's
Right,
quite
okay.
remote. I mean, to be fair, it's not that remote. But by the time you've got someone to you and flown back, and all the faff with, you said your patient there, what you described earlier on, was already intubated. But actually, if they're not, and they're going to require that, and then someone's going to stick an art line in and a central line, then actually you're never going to get there quick enough, are you? Especially if you've got a transfer flight. So you could see in an environment where you're very remote that actually this is something that potentially you could consider. I'd say I'm talking here, but it's an environment that I would think is incredibly rare in the UK, because you're never a few minutes from a major trauma center.
Yeah, and you're obviously, because of that background, you're familiar with case reports of someone using the local Black and Decker drill to save a life,
and you see it,
illustration.
And you go, oh, that's well done. But it still makes me feel a bit nervous. So yeah, try not to do. If you have no choice, then obviously you've got to do what you're going to do. But if you can prepare, let's say if you work in a remote area and you're watching this and thinking about this, just look up perforated drill bit and get one and leave it somewhere in the ethos trolley somewhere.
You can get them on eBay.
Probably.
So just to summarize then, with all the halo procedures, the hardest thing often is the decision rather than the actual technical aspects, as long as you've rehearsed and had a chance to practice, preferably on a cadaver course, preferably under the supervision of a neurosurgeon. But the rehearsal and the practice is one thing, but the decision to go is one of the hardest. And in this situation, we would really want people to be making that decision with a neurosurgeon who's got on the phone, who has seen a CT. So this is a procedure where you have a CT scan, you've got a diagnosis, you know exactly what the pathology is, and importantly, where it is. And the neurosurgeon can help you with your landmark, so that you're going to go in the right spot, so that before you get into the skull, you don't go through vessels, and when you've got into the skull, you get in the hematoma, not into the brain. So you really need the expert guiding you on this. And as you say, with communication capabilities that we have now, there's no real reason not to do that. And then indications, of course, the perfect patient for this is the talk and deteriorate patient. They were GCS 15 after their head injury. So there's minimal or zero primary brain injury. This is all a secondary phenomenon because of bleeding inside the skull that's affecting the brain. This is secondary injury that we're trying to treat. And so this is a completely salvageable patient, a salvageable brain if we can decompress the pressure inside the skull. And then the thing that makes it urgent is the deterioration to the point of GCS3 and signs of impending or actual herniation. So you're losing your pupillary response. And you're weighing up, again, in consultation with your receiving neurosurgeon and whoever's responsible for in-hospital retrieval, you're weighing up your ability to get this patient to the surgeon in time, whether someone locally has to do it under that neurosurgical guidance. And then you're using the best possible kit for the procedure. And if you've watched this conversation on YouTube, you haven't got any excuses. Next time you're at work, you can have a think about what kit you should be getting in place for this and for people to be trained in its use. So just on that blown pupil bit though, Mark, when should we be nihilistic about it, or should we always be optimistic about it? If we've got that talk and deteriorate patient, they've blown the pupils, but we've seen the pupils get blown. We knew this patient was fine an hour ago. How interventional should we be in that clinical scenario where we've lost both pupillary light responses?
Yeah, so pupils are often seen as a sort of like the be all and end all in all this, and there is an element of, it's true, if you've got fixed dilated pupils, odd shape, it's been a long while, then that's very, very, very bad sign. But there are many reasons people might dilate their pupils. They might dilate them because they're on some medication, drugs, they could have had a seizure, they could have orbital injury. There's lots of other reasons. And the other thing to think about is pupil dilatation means there's pressure on the oculomotor nerve, and there's causing shift basically, and that's it's a measure of shift more than anything else. So if you've got something like an extradural, your that bleeding is bound by the dura, so the shift is occurring, but the pressure is kind of held back a little bit by the way the dura is stuck to the inside of the skull. So you can dilate people up and have that treated and still do completely fine. Whereas if you've got something like a subdural, which is much more over the surface of the brain, causing more shift and not restricted by the dura, that pressure's directly on the brain. So if we did a meta-analysis a few years ago looking at fixed dilated pupils, and people with extradurals actually still do okay if they've got fixed dilated pupils, a lot of the time. Whereas with subdurals, the nihilism is probably more real. That is a bad thing. And on that note, as I say, the blood in a subdural, not a chronic subdural like an elderly person having a chronic subdural, but in an acute subdural, come off your motorbike, young person, that blood is clotted, and that just doesn't come out through a burr hole usually, unless they've got some coagulopathy going on as well. I get the nihilism when it's a subdural, really bad injury, big blown pupils, bilaterally, odd shape. But you've got to look at the context of everything. So the patient, so older patients, alcoholic patients, in my experience, got no evidence of this whatsoever, who've got more atrophic brains will tolerate more shift. So they'll probably blow their pupils, and actually, if you drain them, they do all right because they can tolerate that shift still. Whereas if you've got someone who's younger or more full brain, not atrophic in any way, they won't tolerate that shift as much. If they blow their pupils, then that's kind of worse in terms of outcome. That's really broad brushstrokes. It's one of many things. So you can use, as we talk about devastating brain injury, which is a term I really don't like, because in my opinion, it's very much my opinion, a devastating brain injury is when you have someone who's got devastating scan, like the scan looks awful, which is not usually an extraaxial hematoma, like subdural and extradural, because that's not a brain injury. That's blood everywhere in the parenchyma or massive diffuse axonal injury or hypoxic injury. That's a bad scan. So you've got bad scan and then bad neurology. So you have to have the two together. So bad scan, bad neurology, that's bad. If you've got bad scan, good neurology, well, keep going. If you've got good scan, bad neurology, keep going. But two together, probably it's bad outcome. So I still don't like the word, but devastating, because you don't know it's devastating until afterwards, effectively. So it's a retrospective thing. So, I don't like calling it that up front. But I kind of you've got it's a bit of a soup of stuff, isn't it? So you've got to look at the whole lot, pathology, patient, to be nihilistic about it.
We know our indications. We've got the scan. We're thinking about, oh gosh, we've got to get them to a neurosurgeon, or things are so far gone, maybe the neurosurgeon is going to get us or our surgeons to do it. I think it's probably worth just reminding everyone that you still need to resuscitate the patient. So we've still got to do the ABCs properly before we go stampeding towards them, drill in hand, and thinking about optimal oxygenation, control of the CO2, protection of the airway, head up, etc. Anything to say on that or
Yeah.
add to that?
No, I think what you've hit now, there's this big task focus thing, isn't there? You know, whether it be Reboa or whatever you might be doing, everyone focuses on the exciting thing and forgets all the basics. So, but the basics are the really important bit here. That's what's going to keep the brain perfused in the standard sort of, cerebral perfusions minus ICP mentality. But looking after the rest of the patient holistically is just as important as what you're trying to do as the definitive treatment, probably.
Does osmotherapy do anything in a pure extradural?
I don't know, but the interesting thing about osmotherapy is how it works. And I don't know if everyone really appreciates sort of how it works. Everyone thinks it sort of draws in fluid, well, from your into the intravascular compartment to lower the intracranial pressure. What it's doing, first of all, when you give it, or my understanding is you're improving the rheology of the blood. So basically, you're pulling in extracellular fluid from everywhere. So from from your outside your cranium, basically, you're hemodiluting yourself, improving the rheology of the blood, perfusing better, and that's why it works quite quickly. You know, if you give hypertonic saline or mannitol, you sometimes see people come down like within a couple of minutes. And, well, how does it work that quickly? And it's probably just improving blood flow briefly. Then it does the classic osmotherapy thing of pulling more extracellular fluid into your intravascular space. Now, whether or not it might buy you a few minutes to get someone into theatre, but it's not really a good temporizing thing. It's literally just going to buy you a few minutes. The old world of hyperventilating is seen as a bad thing, as you know. But again, maybe if you're on your way into theatre and they're blowing the pupils, that's the time to do it. Yeah, these little things are probably help a bit, but at the end of the day, they're going to need the clot removing.
Right. Lovely. And then just because I know people are going to be fixated on this, I just want to summarize the potential issues using an easy IO. So for going through the skull, number one, that's not what it's for. Number two, no neurosurgeon would consider that a definitive technique. Number three, whether you're using the pink, blue, or yellow needles, they're all the same gauge. They're all the same diameter, and they're going to be too skinny to get clots out. So if you can get some runny stuff out through it, you might get some volume out, but you might not get anything out. And that, in my mind, that's analogous to, a traumatic hemopericardium. Often a needle pericardiocentesis is not going to do much because you've got clotted blood in there. Whereas there are case reports of it working, and we might have seen individual cases of it working, the same as there are case reports of the EZIO temporizing. A lot of the time it's not going to work. And I guess the last thing about the EZIO is you still want your neurosurgeon on the phone saying, okay, if that really is all you've got, then fine, but you're doing this with a neurosurgeon on the end of the phone, and it's not your preferred device.
Fair enough. But you always do all this with your local team, talking you through anything. And if you've got nothing else, then fair enough. But being prepared. If you're watching this, no harm now. Go and get a perforated drill bit. Probably about 20, 30 quid. So not too expensive. Have it probably.
We've got a nice halo trolley in our ED, but we don't have anything for burr holes in it. And
but you can probably get to a neurosurgeon. Yeah, exactly.
Yeah. Beautiful. Thanks for that. Any closing comments for why you've got an audience who need to hear some stuff from a brain surgeon?
Not really. Only just this is like a hook really. It gets people interested in brain injury. But you've got to remember there's many different types of brain injury, whether it be extradural, subdural, diffuse axonal injury, hypoxic brain injury, parenchymal injury from contusions. Those are and they're not the same injury. They're all different pathologies. And we probably should manage them all differently as well, but we don't really understand, certainly in the early phases, maybe what's going on inside that patient in front of you until they've had a CT scan. And we haven't really done the studies to show what optimal blood pressures you should have for the different things. There's obviously TXA, which probably reduces bleeding in some of them, but we don't know which ones really. But brain injury is a spectrum of disease. And we just talked a bit about extradurals here. That's a tiny little bit. That's a relatively rare bit. And the other thing to say about this is obviously it's a disease that has a huge impact on the patient, obviously, on their family massively, on society considerably, because people often are not quite right after they've had a brain injury and they need support from the community, and or they may it has a lot of other effects, societal effects, certainly accumulating regular small brain injuries. So it's a really interesting area of medicine, and I'd encourage anyone who's watching who's interested in this to get involved with it, because at the end of the day, it's the most important area of brain in medicine, like brains. So yeah, that's what I'll say about that.
So there we have it, Mark Wilson's views on using EasyIO for resuscitative needle craniostomy. Why would you, if you're in a position where you may have to do this, just get the right equipment for your department and your service in collaboration with the neurosurgeons? There's lots of options there, but be prepared rather than take a chance on the day. There are links in the description below, including the case reports of EasyIO use for resuscitative craniostomy, the paper Mark mentioned on how to do burr holes. There's also a video on how to do burr holes, and the World Health Organization guidelines on how to do burr holes. Thank you so much for listening and watching, and thanks so much to Professor Mark Wilson for such a fantastic perspective on an area that we deal with rarely, but he deals with all the time. Thanks, Mark, and thanks, everyone.